Hello, everyone. On behalf of the Initiative for MPTs Secretariat staff, I would like to welcome you all and thank you for participating in today's webinar on modeling the potential of MPTs. I am Bethany Young-Holt, and I direct the Initiative for MPTs. This is the second in a series of technical webinars that the IMPT will be hosting this year, all examining critical issues for MPTs. If you missed our first webinar on bioavailability and bioequivalence, the full recording is available on the IMPT website. I would like to now introduce my colleague, Laura Delplane, Program Associate with the IMPT Secretariat, to give a bit more background and context for this exciting webinar. Thank you. Laura?
Thanks so much, Bethany. So I'm going to be giving a brief overview of MPTs, the IMPT, and the landscape of work in the MPT modeling space to frame our very exciting primary webinar presentation and robust discussion. So as many of you may know, multipurpose prevention technologies, or MPTs, deliver simultaneous prevention of at least 2 sexual and reproductive health risks: unintended pregnancy, HIV, and other STIs. The ideal products would be extremely safe, affordable, and easy to use. There is an array of MPTs in development, and this is really critical as it will be important to have a range of products to fit the diverse needs of women in different stages of their life and in different settings. The furthest along in the pipeline, as some of you may know, there are a number of vaginal rings that use different drugs to prevent HIV, unintended pregnancy, and even other STIs like herpes. In addition to rings, there are fast-dissolving vaginal films, vaginal and rectal inserts, and vaginal and rectal gels that can address multiple risks. Some products in the pipeline combine contraception with HIV prevention. Some combine contraception with protection against other STIs, and others prevent HIV and other STIs while allowing for conception. You can see the full list of products in development in the IMPT's online product development database. So this is on the IMPT website. The initiative, Bethany and I are part of the Secretariat of the Initiative for MPTs. The initiative is a product-neutral international collaboration of experts working together to advance the growing MPT field. With a long-term strategic vision for the field, the IMPT Secretariat facilitates collaboration among MPT stakeholders to optimize product development and introduction efforts, ensuring that work is complementary rather than duplicative and aligns with identified research priorities. One of the technical priorities identified by the IMPT is around modeling the impact potential for MPTs. As part of our process to address this priority and propose a way forward, last year we conducted a landscape review of MPT modeling activities. Through a literature review and key informant interviews, we identified 4 primary relevant published and ongoing MPT modeling projects. All projects that we identified used data from South Africa. And very briefly, these included 2 discrete choice experiments, a complex model of the health impact and cost effectiveness of a contraceptive and HIV prevention intravaginal ring, and a model of the health impact of a co-administered pre-exposure prophylaxis long-acting injectable and DMPA. We're going to go into a lot more detail on the health impact and cost effectiveness of the intravaginal ring in our primary presentation. More details on all of these projects and identified MPT modeling research gaps can be found in our project report, which is also on the IMPT website. I am now very pleased to introduce Dr. Íde Cremin of the Imperial College London, who will be giving the main presentation on one of those highlighted MPT modeling projects I went over. She also presented on this work at the IMPT's technical workshop on clinical trial evaluation and design issues this past September. Íde Cremin's research interests are using mathematical modeling as a tool to quantify the potential impact of prevention interventions on HIV transmission in different settings in sub-Saharan Africa. The main focus of her work is on the epidemiological impact and cost-effectiveness of pre-exposure prophylaxis and multipurpose prevention technologies in the context of combination prevention. Íde, thank you so much for joining us today.
Great. Thank you very much for that introduction, Laura. And thank you to the initiative for MPTs for inviting me to present on today's webinar. And thank you also to everybody who has joined today. And I'm pleased to be able to talk about some work which I have completed regarding the potential impact of multipurpose prevention technologies for HIV prevention and contraception. And so I'd like to begin by first taking a step back to briefly introduce the role of mathematical modeling and say what it is for those who are not so familiar. And essentially, mathematical models are a quantitative representation of a system, for an example, an epidemic of an infectious disease. And modeling is a way of thinking about a problem, and there are many different types of models. They can range from being very simple to being very complex, and writing equations helps to make assumptions explicit. And so the type of model that's used depends on several things, including the question that's being addressed, the understanding of the underlying system, and the data that's available to inform the model. And with the model, data and assumptions are used in order to produce estimates and projections into the future. And so models can be used to estimate the population level impact of a public health intervention. And therefore they can be useful also for framing policy questions regarding program delivery. And the aim of this work is to estimate the impact and cost effectiveness of a dual-use intravaginal ring for HIV and for contraception in South Africa. And we chose South Africa for several reasons, as there's a high level of HIV prevalence, where approximately 19% of the adult population were living with HIV in 2012. So that's an estimated just under 7 million persons. It also has high levels of unintended pregnancies, and there remains an unmet need for contraception. So it is a setting in which a dual-use product could provide some impact. And so I'd like to begin with the main findings of these analyses. And an MPT at realistic levels of coverage could avert substantial morbidity and mortality in South Africa. And in addition to the key assumptions regarding efficacy and adherence, the delivery strategy, which essentially reflects who receives the product, was found to be an influential determinant of the impact. And we looked at 4 possible delivery strategies, and of these, a primary healthcare delivery scenario was found to be the most cost-effective. This scenario assumes broad access by women aged 15 to 49 years as conceptualized as delivery through the existing public healthcare system. And overall, an MPT does have the potential to be a very cost-effective intervention, and even possibly cost-saving under some scenarios if low cost and high efficacy can be achieved. And so I'd like to present this work in 4 sections. And so firstly, I'll give a brief description of the model and its calibration to the data from South Africa, followed by an overview of the analysis and assumptions, then giving the results, and finally a brief discussion regarding the limitations and data requirements. And the model we're using is a deterministic compartmental model of HIV transmission, fertility, contraceptive use, and pregnancy outcomes. And so a lot of detailed data has gone into informing and parameterizing this model. And following previous work, it is stratified by age in single years, sex,
Also behavioral risk groups, and we have 3 risk groups in the model with different levels of partnership formation and condom use. And also condom use is assumed to change over time to reflect the reported increases in South Africa. We also include male circumcision status, so all men are distinguished as either circumcised or not, and antiretroviral treatment use, as has occurred in South Africa, is represented, and of course the model contains a detailed representation of an MPT intervention. In terms of demography, we're representing the population of South Africa at a national level, so the full population for the country as a whole, and we have included time-varying age and sex-specific mortality rates and also age-specific fertility rates, and these were obtained from the Actuarial Society of South Africa. And the figure on the right is showing population pyramids from the model at 5-year intervals, and these are calibrated to the data from the Actuarial Society of South Africa model in order to give an accurate reflection of the demography of South Africa. And in terms of reproductive health outcomes, we are looking at impact of contraceptive use on unintended pregnancies and then on the subsequent numbers of unsafe abortions and maternal deaths. In terms of calibrating to the HIV epidemic, we have calibrated the model to prevalence and incidence data from several nationally representative surveys. And the panel on the left here shows model prevalence over time and how it compares to the antenatal clinic data and also to the HSRC survey estimates. The panel on the right is showing modelled incidence over time and how that compares to the nationally representative HSRC estimates. And you can see that for this model fit, incidence peaked in the late 1990s and subsequently declined. And for our intervention period that we analyse, incidence, modelled incidence is dipping to just below 1 per 100 person years. In terms of interventions which have been scaled up, we include a representation of the treatment and male circumcision programs. And here the panel on the left is showing the modelled number of people on ART over time and how this compares to data. And the circumstances under which ART can be initiated for infected individuals changes over time in the model to reflect changes in national guidelines and practice. And the timing of these threshold changes is calibrated to the total number of people receiving ART in South Africa. And also provision of ART is projected to continue increasing in the future, such that the total number of infected individuals on ART and virally suppressed reaches 81% in accordance with the UNAIDS 90-90-90 targets. And on this slide, the panel on the right is showing the modelled level of male circumcision over time and how this compares to the HSRC estimate. And so we've captured the increase from 2009 to 2012, and we are also assuming that this increase continues into the future. In terms of reproductive health outcomes, we have also calibrated to maternal mortality, and we assume that HIV-infected women have a maternal mortality rate that is 10-fold higher than that of uninfected women. And here we are capturing the increase in maternal mortality due to the HIV epidemic. Okay, and this slide is giving an overview of some of our key assumptions regarding MPT use in the model. And so we're assuming that the product is an intravaginal ring, which can be prioritized by age and also by behavioral risk group. And so women who use the ring can either be new contraceptive users or displaced from a different form of contraception. And so this is parameterized as the proportion of users who have switched from other methods of contraception. And adherence in the model is defined as the proportion of sex acts which are protected by the ring. We're assuming that users have a mean duration of use of 5 years, and for some women this will be longer, for others it will be shorter, but the average is 5 years. We also assume that all women who start using the ring stop using condoms regardless of their reason for using condoms initially, whether that was for HIV and STI prevention or whether it was for contraception. And in terms of protection, the ring provides protection against HIV and pregnancy. And the HIV protective efficacy, that is with perfect use of a vaginal ring, is unknown. And so the likely adherence that women will achieve using the product is unknown also. And the only information available on these points come from the recent Aspire trial for a vaginal ring containing dapivirine for HIV prevention. And so 2 estimates of effectiveness are available from the Aspire trial following the exclusion of 2 study sites with lower than expected protocol and product adherence. And so these are 37% among women aged 18 to 45 and 56% among women aged over 21. And so these 2 estimates were used to calculate lower and upper bounds of likely efficacy in this analysis. And so we are assuming higher levels of intrinsic efficacy, i.e. with perfect use. And for contraceptive efficacy, we are assuming a low estimate of 92% based on typical use of the NuVa ring and the NES-EE ring, and a high estimate of 97% based on what's observed with long-acting reversible methods. We also assume that the scale-up of a ring begins in 2018 in all scenarios. The coverage increases linearly, and we then look over a 10 and 20-year intervention period, so from 2018 to 2028, and also from 2018 to 2038. And we modelled 4 delivery strategies, the first of which assumes broad access by women aged 15 to 49 years, and this is conceptualized as delivery through the existing public healthcare system, and we're referring to this as the primary healthcare strategy. The second is as for the primary healthcare strategy, but it reaches additionally women aged 15 to 29 years, so higher coverage among younger women, and so we call this the public healthcare plus strategy. The third strategy prioritizes only young women, so specifically 15 to 29 years, and we refer to this as the youth strategy. And the fourth is a program that prioritizes women at greatest risk of HIV infection, which we call the Women at Risk strategy. And the coverage assumptions for these are based on results from an acceptability survey carried out among women in South Africa on their preferences for a dual-use product. And in terms of costs, we've used some preliminary cost estimates of $16 to $48 per person per year for the PHC delivery strategy. And so these preliminary estimates would include the shipping, delivery, clinic costs, also HIV testing and other access costs. And so for the remaining 3 strategies, the cost was estimated as a function of the unit cost assumed in the primary healthcare strategy. And so the women at risk strategy was assumed to cost 3.4 times more based on another study. The cost of reaching youth through, say, peer education programs has been estimated to be half that of reaching high-risk women. And so we assumed that to be 1.7 times higher than for public healthcare delivery. And finally, the youth strategy was assumed to cost midway between the Women at Risk and the Primary Healthcare Plus strategies, as it combines aspects of peer outreach and a standalone program. And also, I should say that treatment is assumed to cost $682 per person per year, and that's based on a facility level ART unit cost analysis for South Africa. We've used recently estimated cost effectiveness thresholds of just over $8,900 and also $2,221, and these are specific to South Africa. And these were used to define interventions as cost effective and very cost effective respectively. And our perspective is that of the health provider, such that spending on ART and on an MPT product come from the same budget. And all estimates of both impact and spending are discounted at an annual rate of 3%. So now for the results, and this figure is illustrating the DALYs averted with respect to the 4 delivery scenarios over a 20-year intervention period. And so the lower and upper bounds of these bars represent the high and low efficacy assumptions respectively, and the blue bars assume that 50% of MPT users are displaced from other forms of contraception, and the green bars assume no users are displaced. And so what you can see is that the overall number of DALYs averted is lowest for the primary healthcare delivery strategy, but the impact is increased substantially in the PHC Plus strategy, which has enhanced coverage among younger women. Impact in the youth strategy is similar to that in the PHC Plus strategy, but the absolute impact is somewhat lower when the ring is prioritized to women at highest risk, as this is a smaller subpopulation. And also in each delivery strategy, impact is only very slightly increased when assuming no displacement from other methods of contraception, and this is because the majority of DALYs averted are attributable to HIV, because many more HIV-related deaths are occurring in the population as compared to maternal deaths. And in terms of cost per DALY averted, these panels are illustrating the incremental cost effectiveness ratio for each of the 4 delivery strategies. And so we can see that this is lowest in the PHC strategy, and then it's higher for the PHC Plus in youth, and then highest in the women at risk strategies. And this is because the increased impact of the more focused delivery strategies is offset by the higher costs that we're assuming to implement these. And these cost effectiveness ratios are lower if no displacement from other contraceptive methods is assumed. And this is because the women using the ring were previously not using any form of contraception, and so thus there's more reproductive health benefits are gained, and consequently a lower cost per DALY averted. And in the panel on the left, which is assuming a high cost ring over a 10-year period, only the PHC scenario reaches the cost effectiveness threshold. However, over a 20-year intervention period, the impact is improved by about 6-fold, and the cost effectiveness is therefore considerably improved. And this is because a longer intervention period allows the effect on deaths averted to be captured. And so, assuming a low-cost ring here on the right, all scenarios are now falling below the threshold for being very cost-effective, with the exception of the women at risk delivery strategy with a low efficacy ring. And also, if you look to the left-hand side of this panel, that the this scenario is assuming a high efficacy ring provided by the primary healthcare plus strategies. These were found to be just cost saving. And so the cost effectiveness of a dual use ring is uncertain owing to these uncertainties regarding the efficacy and the adherence and the cost. And because of this, we carried out a sensitivity analysis in which each of these parameters were independently sampled for each of the 4 delivery strategies that we were looking at. And so we calculated a cost per DALI averted for each of 2,000 simulations in which the baseline cost was sampled from a range of $16 to $48 per year. Adherence was sampled from a range of 20 to 80% of sex acts protected. Contraceptive efficacy was sampled from a range of 92 to 97%, and HIV efficacy was sampled from a range of 56 to 75%. And so this plot is showing the cumulative probability distribution of the outputs for each of these 4 scenarios. And so assuming a willingness to pay threshold of just over $8,900, here shown by the yellow vertical line, then the probability of cost effectiveness is 97% for the primary healthcare scenario, 86% for the primary healthcare plus scenario, lower at 71% for the youth scenario, and lowest at 49% for the women at risk scenario. And so in terms of reproductive health outcomes, this table is showing some of the reproductive health outcomes that we've looked at assuming a high efficacy ring. And so in terms of impact, assuming 50% displacement from other contraceptives, so the number of HIV infections averted is lowest in the PHC strategy, followed by the women at risk strategy and youth strategy, and highest in the PHC plus strategy. And that reflects about 2.6 to close to 5% of infections averted among women. The highest impact on unintended pregnancies and their subsequent sequelae also comes from the primary healthcare plus strategy. And as well, the greatest reproductive health benefits were observed in the primary healthcare plus strategy, where the number of unintended pregnancies averted ranges from about 95,000 in the women at risk strategy up to over 315,000 in the primary healthcare plus strategy. And the number of maternal deaths averted is relatively low, but it ranges from about 1.8% again in the women at risk strategy up to just under 5% in the primary healthcare plus strategy. And this is because women using the ring are uninfected, and so therefore they have a much lower rate of maternal mortality compared to HIV infected women. And in terms of cost effectiveness, the product is most cost effective when delivered through the primary healthcare strategy, followed by the primary healthcare plus, then youth, and finally the women at risk strategy. And variation in displacement from other methods does not affect impact with respect to HIV infections averted, but it does improve the reproductive health outcomes considerably. So to wrap up, this is the first modelling study which assesses the impact and cost effectiveness of a dual-use intravaginal ring for HIV prevention and contraception. And a ring to prevent both HIV and unintended pregnancy could cost effectively avert mortality and morbidity in South Africa. And the cost effectiveness is expected to be considerably improved when considered over a longer intervention period. The impact of such a product is dependent on both product and user characteristics, but we're finding that one of the determinants of health impact and total cost is the delivery strategy chosen. So whether it's integrated with existing reproductive health services or whether it's provided through, say, new standalone programs. And so programmatic considerations may influence policy decisions irrespective of the product characteristics, provided that a reasonable level of efficacy is achieved. And so a dual-use ring does have the potential to be very cost-effective and possibly cost-saving if low cost and high efficacy can be achieved. And in terms of delivery of an MPT, then a priority group would be women with a dual unmet need for both contraception and HIV prevention, and reaching women who were not existing contraceptive method users did improve the cost effectiveness. However, in practice, reaching these women may incur higher costs, and that is something which we haven't explicitly included. And also I should say that the assumption that women with a need for dual protection can be reached through the existing public health services without large additional cost, this is what's underpinning our low cost per dally averted in the primary healthcare and primary healthcare plus delivery strategies. So for initial product introduction, then settings that currently provide treatment and family planning services would be ideal. So there are several limitations to this analysis, and firstly, in terms of impact, then DALIs are useful to provide a broad measure that capture the dual benefits to both reproductive health and HIV prevention. However, they do not quantify the full burden of sexual and reproductive ill health, and pregnancy-associated complications are often poorly counted unless they result in death. And reproductive morbidities are often inadequately measured, and stigma can often lead to underreporting. And so there's some concern that our main outcome metric is not adequately capturing the impact of averting unintended pregnancies. And the impact of a ring will be affected by women's uptake of and adherence to the product. And so another key limitation of this analysis is that the efficacy and likely levels of adherence are unknown. But our coverage assumptions are in agreement with initial acceptability research among women in South Africa, which found that if MPTs were available, about 10% would choose an intravaginal ring. In terms of the cost effectiveness analysis, we're only including reduced future spending on ART within the intervention period, but of course that would continue beyond the intervention period, and the emergence of drug resistance following inadvertent use of an MPT among women who are already infected has not been included. Our preliminary cost assumptions could be an underestimate compared to what it would actually cost to introduce and deliver such a product in this setting. And when calculating the additional costs and assuming that half of MPT users were displaced from other methods of contraception, we do not take into account that injectable and oral contraceptive pills would no longer be paid for through the public healthcare system for these women, and as a result we may be overstating the additional cost of an MPT intervention. And finally, we have quite a strong assumption that all women who start using the ring stop using condoms. And finally, just to say something about the data requirements for this field moving forward. And so data on the cost and efficacy of a dual-use ring, as well as the feasibility of delivery through public healthcare systems and of attracting young women. Also, data on their behaviours and preferences will be critical for optimising the use of a dual-use ring for the prevention of both HIV and unintended pregnancy. And so in terms of costs, a breakdown of both direct and indirect costs would be useful. And of course, once efficacy is known, then data on to inform adherence and typical patterns of use will be very helpful, as well as more information to inform reasonable assumptions around displacement from other forms of contraception, and particularly condoms. Thank you. So I'd like to end there.
Thank you so much, Íde, for your fantastic presentation. That was really interesting. And I'm sure that many of our audience members have questions. So I would like to now transition into the discussion portion of the webinar. And we've given quite a bit of time for this. We're very excited. I'm pleased to introduce our colleague, Dr. Chelsea Polis, who will moderate the session. Dr. Polis is a senior research scientist at the Guttmacher Institute and holds an associate affiliation in the Department of Epidemiology at the Johns Hopkins Bloomberg School of Public Health. She is a reproductive health epidemiologist who works on issues including contraception, HIV, abortion, infertility, and more. She has particular expertise on intersections between hormonal contraceptive methods and various HIV-related risks. Her ongoing collaborations with the World Health Organization and Centers for Disease Control and Prevention contribute to efforts in updating global contraceptive guidance and WHO's medical eligibility criteria for contraceptive use. Discussants will include Íde Cremin, who I have already introduced, and Matthew Quaife, who we are thrilled is also able to weigh in on the discussion. Matthew Quaife is a research fellow at the London School of Hygiene and Tropical Medicine. He is a health economist and infectious disease modeler working on predicting demand for single and multi-purpose HIV prevention products. He is interested in linking economic and epidemiological insights to accurately predict impact and cost effectiveness of MPTs, particularly in the key populations of adolescent girls, young women, and female sex workers. So, Chelsea, I now pass the baton to you.
Great. Thanks so much, Laura, and greetings to everybody joining in today. Thanks so much for your interest in this webinar. I'm very happy to be joining Cami Health and our really terrific presenters and discussants to moderate the Q&A portion of the webinar today. And I think it's an exciting time, in particular, to be holding a webinar like this. We just saw the IPM yesterday release news that they're starting a phase 1 trial of a dapivirine levonorgestrel vaginal ring. So lots of exciting things happening in the MPT world, and I'm really grateful to our presenters for helping us to think through how we can put the potential impacts and cost effectiveness in context using the power of modeling. So during this part of the webinar, I'm going to get the discussion started by asking Íde and Matt to respond to a few questions that we've put together. But during this time, I'd really like to encourage all of our listeners joining on the webinar to gather your questions and thoughts, as we're going to be opening the line up for discussion a little bit later on. So at any point in time, you can feel welcome to write your questions in through the chat box on your screen, and we'll flag that as a question to ask after getting through our preliminary questions. And if you prefer not to write your question in, but you prefer to speak it directly to the presenters, just gather your thoughts on that question now, and we will be unmuting the line a little bit later in the webinar so that you can ask your question directly. And I'll give instructions on how to do that a little bit later. So I'll move now to our first question, and I'd like to pose this both to Matt and to Íde, starting with Matt. What do you view as the most impactful contributions that modeling can make or have already made to the MPT field? And why would you say that funders in the global health space should be excited about supporting future MPT modeling projects? So Matt, we'll start with you.
Thanks, Chelsea, and hello, everyone. First of all, I'd like to thank Íde for such a great overview of her work and the really interesting summary of what modeling has to offer. I think we're still in the early days of modelling, thinking through how we can adapt our models of infectious disease and HIV for an MPT. But it's a really exciting area to be working on at the moment. And I think Íde's giving a really good overview of the power that models can have to answering some of the key questions that we've got. I think the biggest contribution that modelling offers for MPTs, it starts a conversation that's driven on data. So right now that when we don't have an MPT on the market, then modelling is really our only way of showing that an MPT could be an effective way of reducing HIV infections, particularly amongst adolescent girls and young women where the HIV response is focusing at the moment. Now, when an MPT is developed and we get some data from trials, that data is going to be things like uptake and adherence. But our ultimate aim isn't really to look at how we maximize use of this product. What we really care about is preventing HIV infections and reducing HIV burden in society. So this is really where modeling comes into its own. We can take that data around what we see in these trials and these interventions of product use and predict with our best possible guess the impact that will have in terms of HIV infections averted and unintended pregnancies averted from use of an MPT. Another thing that I think Íde picked up on too is that modelling uses a common language to describe costs and benefits. So our estimates of cost per disability adjusted life year averted and cost per infections averted, they really allow programmers and policymakers to see and compare potential benefits of MPTs alongside other interventions in HIV. So the cost effectiveness of an MPT compared to scaling up treatments or rolling out a single purpose PrEP, for example. But with the cost per DALY averted, the cost for averting one disability adjusted life year, we can compare alongside broader things like distributing bed nets for malaria prevention or investing in drug-resistant TB treatment. So by doing this, we're really able to work out how cost-effective MPTs will be. And I think Íde's evidence and some of our work has shown they're likely to be cost-effective if the cost of these things can be kept quite low. And we can compare that, modelling allows us to compare that across other uses of health money. Now, the second half of your question was why should funders be excited? Why should they be excited as we are about future MPT modelling projects? And I think, although it is a really exciting time to be working in MPTs, without an effective product, we are quite limited as to what we can do. But a sort of a glass half full perspective of that is that we've got an opportunity here to try and work to develop attractive products that people will really want to use, and to use these methods to work out what people want from an MPT and to try and avoid some of the issues that we've had with microbicides, for example, where we've had these really cool, really technologically advanced products packaged and made in a way that were actually hard for people to use in their everyday lives. So I think we've got quite a unique opportunity now to shape that development process and thinking through some of the great work the IMPT is doing about co-packaging and co-formulation and really getting good data on predicting use and using that data well with modelling to predict the potential impact and make the argument for better products that people find attractive. And then I think my final point is that once we've got a good MPT product, we need to show that it will be a really cost-effective way for health systems to spend money. And having a good effectiveness and cost-effectiveness model is really important for that. And my recent work has been in South Africa as well, where a recent investment case for HIV and TB services has led to real commitments in spending and investment from the Department of Health. And that investment case took quite a lot of really high-quality modelling to look at the potential impact of things like introducing PrEP, scaling up condom distribution and HIV and TB treatment. And it also looked at some more innovative things like conditional cash transfers for young women to keep girls in school. So when we've got an MPT that works, we're going to need good modelling like Íde's doing to make a really strong evidence-based case for some funding.
Terrific. Thank you so much, Matt, for such a fascinating and comprehensive answer. Íde, do you have anything to add to that same question about what you view as the most impactful contributions modeling can or has made, or additional reasons for funders in the global health space to be excited about supporting this kind of work that you do?
Sure. So I'll just briefly add to what Matt has already said. And as he said, this is a new field, and so there is a lot that modelling can contribute. And essentially using modelling to provide estimates of health impact and also cost effectiveness is a useful exercise, looking both at the HIV epidemic and in terms of reproductive health outcomes, and looking at estimates of cost per daily averted and how this varies depending on assumptions around who receives the product, how well they use it, what proportion of these women are new contraceptive users, can all be informative. And so in addition, modelling can be helpful in order to explore policy relevant questions such as the influence of age-specific targeting and different delivery options for different populations in different settings. And although MPTs have the potential to provide a really meaningful advance in the field of reproductive health and HIV prevention, as for other health interventions, then efficacy data alone is not always sufficient to guide policy decisions about the role of this product in reducing incidence and unintended pregnancies. And so models can be a useful framework for synthesizing data from lots of sources. So that is on HIV epidemiology and reproductive health and demography program data, and also on cost. And so in summary, the modelling analyses can really help to strengthen the support for evidence-based decision making. And of course, one of the useful aspects of models is that they can keep being updated as new information becomes available. And finally, just to say, I think that the best use of modelling is to interpret the results of the model in light of both the model limitations and also their assumptions.
Terrific. Thank you so much, Íde. And I'm glad to see that we've got a couple questions already starting to come in from our listeners. And I think I'm going to actually shift to one of those at this point because it follows on to some of the presentation that Íde delivered. So Íde, this question is for you from Maggie Kilborn-Brook, and it asks, it seems that the PHC Plus delivery strategy is most cost effective in part because it includes uptake by young women who experience high rates of unintended pregnancy and HIV. But didn't the recent studies show that young women were less likely to use the vaginal ring consistently? And Maggie also is familiar with some of Matt's work and asked about how his data in South Africa about young women's attitudes about uptake of a vaginal ring as an MPT might play in here. And that was actually the question that we were going to go to next about Matt's work around characteristics in South Africa. So Íde, might I ask you to respond to the first part of Maggie's question, and then we'll move into some discussion with Matt about his work in South Africa.
Sure. So that's absolutely right that the studies of the pivirine ring showed that it was the youngest women who were less likely to use the vaginal ring consistently. And so that hasn't been included in this particular analysis. So I'd need to rerun the analysis, assuming that women under, say, 22 have lower levels of adherence. And so I guess here there's an implicit assumption that women who are not adhering to the product would essentially not keep receiving the product, and so there wouldn't be costs incurred with retaining them in a program. Also, here we're assuming there's a slight discrepancy in the age ranges. So here we're assuming that younger women goes right up to 29, whereas I think based on the trials we'd have to refine that to under 22 years. But that is certainly something that we could look at, and I think it would be important to do that in future work.
Thank you so much, Íde. And Matt, as Maggie raised at the end of her question that you may have some data around young women's attitudes in South Africa about uptake of the vaginal ring as an MPT, can you tell us what you've looked at in terms of preferences for characteristics across different populations and the data to predict uptake of different MPTs to inform both impact and cost effectiveness models in South Africa, and how the findings that you've generated should inform our thinking and strategies around MPT modeling and development?
Thanks, Chelsea. Yeah, we just finished some work in South Africa, supported by USAID and Maggie's team at PATH, and we have actually had some really interesting results. A bit of background to the study is that we interviewed 800 people in just outside of Johannesburg, 200 people from 4 population groups. We interviewed men, women, and adolescent girls, 16 and 17-year-olds in the general population, and a group of female sex workers as well. And we carried out a discrete choice experiment to try and understand people's preferences for potential new MPTs. We were looking at 5 different potential MPTs, oral tablets, vaginal rings, injectable delivery, and a microbicide gel which could be used with a diaphragm. And basically our study, this choice experiment, asked participants to choose between 2 or 3 descriptions of hypothetical products. So maybe an MPT vaginal ring against a single-purpose oral PrEP tablet with different characteristics of things like use and side effects. And each participant had about 10 of these hypothetical choice tasks, and by looking at how people made choices across these different tasks, we were able to try and predict uptake of these different products. So I'm not going to dwell too much on those methods, but we plugged in those uptake estimates into a cost-effectiveness model, which wasn't quite as detailed as Íde's, but I think will give us a general picture of impact and cost-effectiveness, and actually we get broadly similar results where those things are comparable. I mean, our headline result is that we found introducing pretty much any product amongst groups with a high HIV incidence was predicted to be cost-effective. So any product really introduced amongst younger women aged under 25, and female sex workers. And we found actually that contraceptive protection was really important to adolescent girls in particular, and slightly less, but still very important to younger women up until the ages of about 26, 27. And as an example, amongst 16 and 17-year-old girls, we predicted that a single-purpose product for HIV prevention would have an uptake of around between 8 and 10%. But if we can add a contraceptive indication to that, we'd predict it would increase 4-fold to around 33%. So, like I say, these numbers are based on hypothetical data, so we don't expect them to be exactly right within a few percent, but it's a really strong message that additional contraceptive protection could increase uptake and use. To tackle Maggie's question about preferences for the vaginal ring, we actually found amongst adolescent girls between age 16 and 17 and younger women up until about 19 or 20, we found a real dislike for the vaginal ring when compared to other means of delivering PrEP. Particularly, adolescent girls particularly valued the possibility of injectable products or oral tablets. And if we could add a contraceptive indication to a vaginal ring, it only just about mitigated the dislike that adolescents showed towards the ring compared to oral PrEP. So there's a bit of a warning flag about potential uptake of an MPT ring. But then there's a bit of opportunity that if we could combine a contraceptive indication into an oral tablet or even an injectable when they come online, there's a real opportunity to get more benefit from the MPT there.
Terrific. Thank you so much, Matt. And I just want to note we're just about coming up towards about 5 minutes until the end of the hour. I want to flag for everybody listening that our discussants will be staying on the line for some additional time to continue the discussion, I think for about another half hour or so. If anybody does need to sign off at this time, any of our listeners, please note that we will be posting the full recording of this webinar on the IMPT website. But we hope that if you're able to stay on the line for the rest of this discussion that you will stick around. We're starting to get some really terrific questions coming through the chat function. I think I'll turn to some of those. I don't see any hands raised, so I'm going to hang off on unmuting the line for now, and I think continue working our way through some of the questions that are coming in through the chat box. So the next question is from Mary Weitzel, and she asks, assuming delivery costs are fairly fixed, do you have a target cost for a ring in this model? And I believe this is posed to Íde. So Íde, would you like to take that question?
Yes, sure. So our approach for this analysis was to use an initial estimate of the range of costs for a ring, and then look at how the cost per infection averted varies with respect to different delivery and efficacy assumptions. But a different approach to doing this analysis would have been to see what would a ring need to cost in order for it to be cost effective. But I guess because there are such big questions about, or such big uncertainties about what the cost might be, what the efficacy might be, what the adherence might be, that we chose to just look at a fixed range. But we could do additional analyses where we look at what the target cost would be, but that isn't something that we have done for the work that I've just presented.
Great, thank you so much, Íde. The next question I'd like to pose, again, I think specific to Íde's model, is from Ellen McLaughlin. Íde, did you model more unintended pregnancies among young women? She says there are major differences by age, and I couldn't tell if you assumed the same rate across age groups.
Yes, so that's a great question. So that's one of the underlying things in the model that makes that has a really strong effect. And so we have used age-specific fertility data from South Africa, and so we do have higher levels of pregnancy occurring among younger women. Whether or not pregnancy is intended or not doesn't vary with respect to age, but yes, we have included higher levels, age-specific levels of fertility, so we are capturing higher levels of unintended pregnancies among younger women.
Thank you so much, Íde. I'll move now to a question that came in from Niraja Bavaraju. And she says, there seems to be some resistance from donors to fully invest in vaginal rings because of uptake and adherence considerations. But vaginal rings also seem to have a lot of promise for cost-effective delivery relative to other options, such as the oral pill or the injection. How do you see the cost of delivery across product forms? And to what extent is it worth it to invest heavily in demand generation and adherence support because vaginal rings have strong potential for cost-effective delivery? So I'd like to pose this question to both of our discussants, and maybe we'll start with you, Matt.
Yeah, a really, really good question. I think it's something that we wrestled with when pulling together our cost model, because there's just no data. There's just no data on how these things come together at the moment and what they will cost. So, I mean, the only thing we can really do is look at the costs of existing HIV prevention products, so really oral PrEP and the vaginal ring, and look at the cost of sort of the compounds and the products that go into the contraceptive products, and just add them together. I mean, there's nothing more complex than that, really, what we can do at the moment. It does vary substantially across product forms. I think with what we found we were using the South African guidelines to model our costs. And the injectable product actually had much more clinic-facing time, because you had to go in for an injection every month, whereas PrEP you could have a 2 or 3 month sort of pot of pills or pack of pills and go away and take it yourself. And the clinic time actually drove a lot of the cost that we saw in the injectable product, which was to an extent mitigated by more optimistic scenarios of impact, where an injectable would be used by more people. My kind of overarching answer to the question is we don't have the data at the moment, and it's something that if anyone does have the data on these sorts of things, then it would be really interesting to share where possible as we move together kind of as a community to make good models of MPT development.
Great, thank you so much, Matt. And Íde, do you have anything to add to that question?
Sure. So that's a really excellent question. And so for what I've presented, we have explicitly assumed an intravaginal ring. But for different formulations of an MPT, you would model them in the same way but make different assumptions about efficacy, adherence and cost accordingly. And so our approach has been given a set of assumptions, then what is the expected impact and cost effectiveness, whereas to what extent is it worth it to invest is a different way of posing the question. And so we could do additional analyses in order to see, based on a fixed efficacy and adherence assumptions, then how much could a ring cost in order for it to be worth it compared to other products. And I think the extent to which you could invest more depends on relative efficacies and relative adherence for the different formulations. And so it would basically be one large uncertainty analysis because there's so many unknowns and so many different moving parts. But we could do some hypothetical scenario analyses around, how much more could a ring cost and still be worth it. So how much extra spending are you allowed to have in order to promote the ring and to support adherence? So what could you be spending on adherence interventions? But I guess you'd need good data that those adherence interventions would actually allow women to achieve the level of adherence sufficient to get the full protection from the ring. But I agree that it would be a very good way to frame these analyses.
Thank you so much to both of you. I don't see any hands raised, so I'm going to assume that means people aren't needing to chime in. So I think we'll hold off on unmuting the line for now unless we start to see some hands raised. But we do have another question that came in through the chat box. And that question is from Polly Harrison. And she asks, are you considering modeling for combination injectable, i.e. contraceptive plus HIV preventative? And I'll start just by noting that I would encourage folks to, Laura mentioned that we recently put together a summary report looking at the status of modeling efforts in the field of multipurpose prevention technology. So if you do want kind of an overview of what's published and what's coming down the pike, you can look for that report on the IMPT website. That report does describe a little bit of work that's ongoing by Dr. David Van de Vidver, and I've been assisting him with that. It's in an early phase, but we are hoping to actually look at combined injectable MPT product. So there's a bit more information about that in the report that's online. And again, I direct people to the IMPT website to check that out. But I'd like to also pose that same question to Íde and Matt. In the modeling that you're doing or future work, are you considering modeling specifically for combination injectables? Matt, maybe we can start with you.
Yeah, sure. So we've, like I said, one of the big downsides of the study we've done is that it uses this hypothetical data and hypothetical choices, but the flexibility that gives us is really good. So we have actually modeled a combination injectable and to see how much how demand and cost effectiveness would be affected by adding a contraceptive indication to a single purpose HIV injectable. Our message that came out of the injectable work was that demand for a single purpose injectable was so high in comparison to other products that actually adding the contraceptive element didn't add a great deal of value. If we're looking to add value by including a contraceptive element, we should focus more on products that are kind of intrinsically less desirable, so such as oral PrEP or the ring or a gel. But because the injectable was already in demand amongst our group, it didn't add a great deal of value when we added the contraceptive indication.
Íde, Íde, anything to add on that question? Is your group considering adapting your work for combination injectables?
Right. So the work that we've done to date has been specifically for an intravaginal ring, and we haven't explicitly looked at an injectable. But I mean, we would, if we were to do it, the approach would be the same. We'd use essentially we'd be refining assumptions around efficacy, adherence, or efficacy, cost, and then typical levels of coverage. So we haven't looked at it, but we would take a very similar approach.
Great. Thanks so much to both of you. I think I'll move to a question that we started touching on a little bit before, but maybe there's some room to get a bit more in depth. And that relates back to when Matt was talking about the preferences that they found in their work among adolescent girls. We know adolescents are at very high risk for HIV in many settings. They're a priority target population for MPTs. Given their heterogeneity amongst that group and the limited HIV microbicide effectiveness data for younger end users, are there ways that one might approach modeling MPT effectiveness differently for a younger population? And maybe I'll start with Íde here.
Yes, so I think that a useful approach to address this question is to think in terms of people and places. And so in terms of people, then there's various risk factors which can be used to identify those at highest risk of acquisition. And so the things classically used are reporting multiple partners, low or inconsistent condom use, having an STI. And in terms of places, then the focus would be on those geographies with the highest levels of transmission first, in particular those locations where high HIV incidence coincides with high rates of unintended pregnancy among adolescents and young women. And as adherence is crucial, then the subset of adolescent girls willing to use an MPT and who could be supported to achieve sufficient levels of adherence that would comprise this initial target population. And so in terms of modeling this target population, then what we would need is specific data on these different groups of adolescent girls in terms of prevalence and incidence, but also in terms of what their adherence would be.
Thank you, Íde. Matt, anything to add on to that same question?
Not particularly. I think that's a really comprehensive answer. The only thing I'd perhaps flag is that in the next, I guess, 2 to 3 years, a lot of money is being spent on rolling out PrEP amongst adolescent girls and young women. And Íde sort of touched on this idea about how do we model people's behavior in migrating away from condoms, which is something that I think her approach of taking the conservative approach that everybody is going to stop using condoms is probably a fair one in this instance. If adolescent girls or young women are using single-purpose PrEP and we start rolling out MPT products, maybe different formulations, we need to really know if the people using these newer MPT products are going to be the people that we're reaching for the first time, or if people are just substituting away from the single-purpose product in order so that we don't overstate the benefit that we're getting.
Great, thank you so much. Why don't we go ahead and unmute the line in case there are folks who are joining just by audio and who aren't able to raise their hands and who may have questions and are unable to type those in. It'll take, I think, just a few moments for the line to be unmuted, and then we're going to ask all of our listeners to mute themselves individually just to limit background noise.
The conference has been unmuted.
Great, so we're unmuted. The line sounds surprisingly quiet, which is good. Hopefully everybody will have a chance to press *6 to mute themselves. But if you do have a question that you'd like to speak directly to the presenters at this time, I'd like to ask you to press *7 to unmute and to go ahead and ask your question. So I'm just going to give it a few moments here for anybody who'd like to jump in and ask your question. And we are hearing a little bit of background noise. Just as a reminder, if you can press *6 to mute if you don't plan to ask a question. If you would like to ask a question, be sure that you're unmuted by pressing *7. Okay, if there are no questions on the line at this time, then I can move on to a few other questions that we have prepared. Again, if you'd like to jump in with a question, you can press the raise hand meeting on your screen, or you can type your question into the chat box on your screen. So this next question goes to both Íde and Matt. What can cost-effectiveness modeling add to the argument for investment in MPTs? And what are the challenges with the economics of MPTs, and how are we overcoming those challenges? So let me start with Matt.
Yeah, thanks, Chelsea. I think I touched on it earlier that cost-effectiveness modeling gives us a real chance to compare health interventions across different areas within health, so across HIV and malaria and TB, but also within HIV as an area of research. So I think cost-effectiveness analyses allow us to really prioritize what is going to be the best value for money. And they also speak to, they speak the language of policymakers, I think, that people are concerned about budgets, and you can do some quite interesting work with some very simple economic methods to show value or lack of value, I suppose, in a model. I mean, one thing that I've really wrestled with trying to assess value within the MPT framework is that our measures of benefits are quite narrow. So at the moment we're measuring benefits and the health benefit from averting an HIV infection, from averting an unintended pregnancy. We use a risk to maternal life. But as someone who comes from a welfare economics background, I find it quite difficult with these narrow measures of benefit, because there's loads of benefit that we're averting from an HIV infection, or from delaying an unintended pregnancy, or averting an unintended pregnancy. So I think there's a lot of work on the method side of things that we still need to think through. But I suppose it's not really related to the case of whether or not to keep getting excited about MPTs in the first place.
Thank you so much, Matt. Íde, anything to add on that in terms of what cost-effectiveness modeling adds, or the challenges?
Sure. So just briefly to say that the cost-effectiveness modeling is useful to provide some estimates of cost per daily averted and how this varies with respect to key influences and assumptions, and also how the cost-effectiveness of MPTs compares to other interventions. So that's useful for assessing value for money. And a key challenge is how to adequately capture the impact of averting unintended pregnancies and the subsequent health effects. And so we're overcoming this by looking for all available data on maternal outcomes and how we can include these in the model.
Great. Thank you so much to both of you. I just want to add that in addition to posing any questions to our discussants, that folks are also free to unmute themselves and add a comment. So do feel free to do that. Perhaps I'll take just a few moments to pause and see if anybody wants to jump in. I think we have someone on the line who has something to share. Okay, maybe not. So we'll move on. We're getting a couple more comments coming in. I'd like to flag one person asked if we could publish all of the questions and answers because they had to leave the webinar. And I just want to remind everybody that the webinar is being recorded, and we will be sending out a link to that after that's posted online. So if you do need to jump off, we completely understand, and you will be free to check in for that link later on and listen to the rest of the discussion. We had another question come in from Polly Harrison. And she asks, does the pharmaceutical industry, which is constantly engaged in tinkering with existing formats, perform comparable modeling exercises to make its investment decisions? Matt, Ida, is that something that you have knowledge of, whether the pharmaceutical industries do this kind of work as well?
So I'm not aware of industry modeling exercises, but that's not to say that they don't exist. It's just I haven't seen them.
Okay,
Matt, are you aware of this?
The economics of introducing new products is quite it's quite a big field in health economics. Less so when it comes to drugs where you can't make a great deal of money, such as HIV prevention products, things afflicting low and middle income countries. So the pharmaceutical industries know the algorithms by which we commission drugs, particularly in the UK. The National Institute for Clinical Excellence has got a very open framework of how it commissions drugs. So pharmaceutical companies are able to reverse engineer their calculations and how much their drugs should cost to kind of make sure that they are commissioned. And it's a bit of an industry for consultants in reverse engineering that methodology. How that applies to the HIV field, I'm not sure. There's a slightly different framework. I mean, the fact that Gilead are giving away PrEP products for free in these trials is kind of unheard of in our kind of economic side of things, particularly in the UK. And how the existence of global funders and funds to encourage innovation within the PrEP space, it probably changes things quite a lot. So the modelling does go on. It's probably a bit more murky in HIV actually than in some other areas.
Thank you so much, Matt. I see no hands raised, and we don't have any other written questions at this time. So I'm going to move on to another question that we had posed for you, which we've already touched on to some extent in questions before, but I'll let you tell me if there's additional points to be made, which relates to how can we really better consider end-user preferences in our models? How are we incorporating what we've learned from recent trials of microbicide gels or vaginal ring trials around adherence challenges? And how can we address in modeling studies the fact that other preventative products or strategies might be more attractive to certain populations of users? So anything to add to this question beyond what's already been said? And maybe I'll start with Ida.
Yes, so regarding adherence challenges, in the model we distinguish different types of users. So we have distinguished both poor and good adherers. And regarding user preferences, we have aligned our coverage assumptions with data from initial acceptability studies. So we acknowledge that other products or formulations may be more attractive than a ring. And so, for example, only 10% of women in an acceptability survey in South Africa said that they would, their preference would be a ring. And so we've used this as the upper bound for our coverage assumptions in our analysis.
Thank you so much, Ida. Matt, anything to add to that as well?
Not really. I think we've discussed about it a bit already, and actually our work has used these stated preferences. I mean, what we really need is how people are going to choose between these products. Are people going to choose to carry on using or not using condoms, to use a single-purpose product or a multi-purpose product? And we can do all the hypothetical studies that we like, but up until the point that we get some revealed preference data on what people actually choose, it's very difficult to envisage how these things could roll out. One thing that we are doing is looking at how we're doing a bit of work with the Options Consortium just around oral PrEP, not a multi-purpose product, but looking how structural factors, so exposure to the violence, exposure to household hunger and low socioeconomic status kind of interacts with people's preferences for new products. And we find that lower, less intensive products you don't have to use every time you have sex or take a tablet every day, are more attractive to people living more difficult lives subject to these structural factors.
Thank you. I'm going to throw it back out to the folks joining in on the line. If you'd like to chime in with a comment or a question, press *7 to unmute, and feel free to share your thought or question. I'll give a few moments just in case anybody would like to chime in. It's *7 to unmute. Okay. Otherwise, let's talk a little bit about challenges and limitations in the data. So when you are working on MPT modeling, what would you say are kind of the key limitations or the data gaps that really still need to be addressed, particularly to ensure that future MPT models are as robust as possible? Matt, let's start with you.
Yeah, I think Íde's actually done a really good job of pointing out the limitations of the models that we use and how the assumptions we make can really affect the results that we get. I guess a simple example is if we consider a group that may be at higher or lower risk of HIV. So even within adolescents, there's quite a variation in risk that people will be at. And there's going to also be a variation in use and adherence that people, how well people can use these products. And we really need to understand if those at the highest risk are also at the best or worst place to be able to use those products well and consistently and adherently.
Íde, as Matt said, you gave us a really great overview of some of the gaps and limitations. Anything else that you haven't mentioned yet that you'd like to add here?
Well, just to summarize, the main data gaps are currently regarding efficacy and cost, and then beyond that, information on user preferences and adherence will be important to inform future analyses.
Great. Thank you. I don't see any other questions coming in through the chat box. We're coming up near the end of our time together. I think we've got about 5 minutes left. So I'm going to give one more opportunity for folks if they'd like to speak directly to the presenters with a question or a comment. Please feel free to unmute yourself using *7 and ask your question or share your comment. We'll give a few moments. Okay. If there's no other questions, I will wrap up with the last question that we have here, which is, and maybe if we could switch to the subsequent slide, it might help. There we go. Thank you so much. So if we consider the range of possible product configurations for a contraceptive HIV protective MPT, we can think about these as being co-formulated, co-administered, or co-packaged. So this slide is showing an example of each. A co-formulated product might be a single vaginal ring that simultaneously delivers hormonal contraception and antiretroviral medication to prevent HIV. A co-administered product might mean that a healthcare provider is delivering, for example, 2 injections at the same time, one being a contraceptive injection and another being an HIV preventive injection. And an example of co-packaging might look like marketing oral contraceptive pills in the same package as something like Truvada to prevent HIV. Do these different kinds of product configurations offer different levels of feasibility in terms of coming to market, or lessons learned from other products that have tried different presentation approaches? And in thinking about how you put together models around MPTs, does the product configuration here impact how you would think about constructing models for various MPTs? And I'd like to actually first start by asking if Bethany Young-Holt would like to weigh in. I know she had some particular thoughts around this question that she may want to share.
Yes, thanks, Chelsea. So the initiative for MPTs, and I know several of our other partners, have been thinking about the potential of co-packaging combination oral contraceptives with oral PrEP as a potential faster opportunity for an MPT product strategy versus current co-formulated or co-administered strategies, in that they may achieve higher levels of adherence versus what has been reported for PrEP alone. They also have the ability to affect the ability to study key elements of MPT access and delivery in advance of availability of co-formulated strategies. Co-formulated strategies have also been, shown to be effective for other indications like cholesterol and cardiovascular disease. So the question that we really are interested in is what modeling considerations should we be thinking about to sort of inform this potential strategy in moving forward?
And for those modeling questions, Íde, Matt, do you have thoughts on that particular question? Matt, maybe we'll start with you.
Yeah, thanks. It's a really interesting one. Whenever we've presented of these multi-purpose prevention product data to people, particularly in South Africa, actually, people have said, well, this doesn't exist now. Why can't we just put them in the packet together? And I think it's a real opportunity to certainly explore more. So I really applaud the IMPT for considering it. In terms of modeling, I guess going back to, again, what Íde said, the cost and adherence, we need to know how much these things will cost. Presumably, co-formulation would have a huge cost associated with development, which we wouldn't actually normally include in our model, but perhaps should if we're thinking of that money should come out of the same budget as current HIV prevention options. If we can get these things co-packaged, we need to know how they're going to affect adherence. I mean, it's feasible if adherence to tablets and other single-purpose HIV prevention products is low at the moment. And our research in South Africa has shown that unintended pregnancy is a key driver, is a key concern for particularly adolescent girls and young women. Then it's kind of feasible that adherence to both could increase, which will impact our models. So we may actually be conservatively estimating our models if we assume a lower bar of adherence.
Matt, thank you so much. And Íde, last thoughts on the product configuration and how the interplay with constructing an MPT model?
Yes, thank you. So for a co-formulated product, then in the model we would have a single user group who receive the product who receive both the HIV and contraceptive benefits. And so we would need different assumptions about the efficacy of each as we currently do, and we wouldn't have different adherence assumptions as it's a single product. Whereas for a co-administered product, it would depend on what the formulation, what the mode of delivery is, as an injection would have a very different adherence assumption as compared to a ring or a pill. It would just depend on how frequently women return for injections. And that's in contrast to a co-packaged product where we would need to make different assumptions about the level of adherence to each product, because if Truvada and a contraceptive pill were provided in the same package, it would be possible to take one, not the other. And so that's something that we could explore in the model.
So lots of interesting questions still to be looked at. We are near the end of our time together. I would like to really give a lot of thanks to Íde for her excellent presentation, to both Íde and Matt for a really rich discussion and a lot of useful insights for moving forward. I'd like to thank the IMPT for asking me to join and moderate this Q&A today. And of course, to all of the listeners and participants who have joined in and for sharing your excellent questions with us. Laura, over to you to wrap up.
Thanks so much, Chelsea. And I want to echo my thanks to Íde for her great presentation, and Matt for your insights in the discussion, and Chelsea for doing such an excellent job moderating, and for the audience for your great thoughts and questions, and for all that you do to support the health and well-being of women and girls around the world. Thank you so much for joining us today. And this concludes our webinar on modeling the potential of MPTs. And as Chelsea said, a recording from today's webinar will be available shortly on the IMPT website. We'll send the link around. Have a great rest of your morning, afternoon, or evening. Thanks, everyone.